Hi, I'm Michelle Kittleson, Professor of Medicine at the Smith Heart Institute, Cedars-Sinai in Los Angeles, and Associate Editor for JACC. I'm delighted to be joined today by Dr. Ron Witteles to discuss Vutrisiran improves survival and reduces cardiovascular events in ATTR amyloid cardiomyopathy, Helios-B. This study we presented at the European Society of Cardiology Heart Failure meeting with simultaneous publication in JACC. Dr. Witteles needs no introduction, but I'll introduce him anyway. He is a professor of medicine at Stanford and serves as co-director of the Stanford Amyloid Center and the Stanford Multidisciplinary Sarcoidosis Program. He is also an associate editor for JACC CardioOncology. While most other people would be happy with all those responsibilities, Dr. Witteles is also program director for the Stanford Internal Medicine Residency Program, which basically means he never sleeps and we should nominate him for sainthood. So let's talk about the trial. Helios-B was a randomized controlled trial of vutrisiran versus placebo in patients with transthyretin cardiac amyloidosis. In an amazing win for patients with ATTR-CM, vutrisiran was associated with a significantly lower risk of the composite of all-cause mortality and cardiovascular events. Treatment also preserved functional capacity, quality of life, and was FDA approved in March 2025. In this pre-specified analysis of Helios-B, Dr. Witteles and colleagues assessed the effect of vutrisiran on all-cause and cardiovascular mortality, as well as cardiovascular events such as hospitalizations and urgent heart failure visits. They observed that vutrisiran reliably reduced the risk of these outcomes. So first question for you, Dr. Witteles, tell us how the results of these studies offer incremental insight to those of the primary trial.
Yeah, thanks so much. It really is such an exciting time for people like you and me who treat patients with this disease to have really, truly effective treatment options. So as you referenced, the main trial of Helios-B, which was reported out last year, showed tremendous success in really all endpoints, including on cardiovascular hospitalizations and all-cause mortality. So what this manuscript looks at is, I would say, two big incremental additions. Number one is that it has longer follow-up. So the main trial had a rather unique design when it was looking at all-cause mortality. This was pre-specified, which was that after the double-blind period, everybody had the option of going into the open label extension and the all-cause mortality included data from the open label extension for up to 6 months. But at the time of the presentation last year and the original publication of Helios-B, only 42% of people had completed data through 42 months, which was the time period we're talking about. So what we have here is now almost everybody, 96% of people have completed through 42 months. So from an all-cause mortality standpoint, we're able to look at that and indeed found that with the additional 6 months of follow-up for many patients, that the benefit on all-cause mortality was at least as good, in fact, numerically a tiny bit better than what had been reported last year. So that's number one. Second thing we did is look at in more detail, more granularity, what these outcomes were. So things like the specific CV mortality events, heart failure hospitalizations, urgent heart failure visits, and so on. And as you referenced, each one of these markers was clearly better in the vutrisiran group. The other unique part that I would say of the trial design here was that it was designed to look at both the overall population of a little more than 600 patients, and then the 60% of patients who were not on baseline tafamidis. And it was actually powered to look at both of those groups. It was not powered to look at the group who were on baseline tafamidis, but nevertheless, there's obviously interest in that. And I would say for virtually every outcome in the two groups that it was powered for, it showed statistically significant improvements in each one of these outcomes that I mentioned, and favorable trend in the underpowered baseline tafamidis arm.
Amazing. I mean, you heard it first, straight from the source. Really exciting incremental insights to help our patients. A win-win, good news all around. Two more questions for you. Next, SGLT inhibitor use was 10-fold higher in Helios-B than in prior trials with the TTR stabilizers. And despite this good heart failure management, vutrisiran still had benefit. So tell me, do you think things like SGLT2 inhibitors MRAs are essential medications for your patients with cardiac amyloidosis?
I do. Of course, we don't have randomized prospective clinical trials looking at this and probably never will. It's just not a big enough population. However, we obviously know that these are agents that work in HFpEF, and in some of these patients, they're HFrEF, but let's say the HFpEF group, number one. And number two, if you think about these are really the sort of ultimate restrictive cardiomyopathies, and if they work in general HFpEF populations, we'd have every reason to think that they would in the amyloid populations. In addition, there have been analyses, including some that have been published in JACC journals, that have looked at things like SGLT2 inhibitors in amyloid patients, albeit retrospectively with propensity matching, and clearly seem to show benefits. Anecdotally, I imagine you've seen the same. Patients do a lot better on these agents. So I do think that SGLT2 inhibitors, and in most patients, MRAs, make sense for this population. But as you pointed out, that doesn't mean that the amyloid-specific therapies don't work. They're every bit as important. And of course, they're attacking the disease from a very different standpoint. So these amyloid-specific agents are obviously directly affecting progression of the amyloid deposition itself.
Amazing. So we have GDMT that seems to be effective for amyloidosis, and we have disease-directed therapy, which brings me to my last question. Everyone listening is on the edge of their seat because what they really want to know is how they can take these results and translate them into clinical recommendations for their patients. So we know tafamidis works. We know acoramidis works. We know vutrisiran works. How do we figure out which of those one or more agents we give to our patients with cardiac amyloidosis?
So you saved the most challenging question for last, and it's the most challenging because there isn't a right answer. In fact, what I tell to patients is that there's only one wrong answer here, and that's to be on none of the therapies, that we have three effective therapies. And, you can make a case for each one of them. I think that it comes down to what I've been doing, and I imagine you've been doing as well in clinic since the approval, so that we've had three agents. And frankly, even before that, once we had the data from the clinical trials, is to outline what we know about the three. Clearly, one of the differences is that vutrisiran is given as a subcutaneous injection every 3 months. The others are pills, either once or twice daily. So for some patients, they prefer one versus the other. Sometimes there's going to be differences from an insurance coverage standpoint, Medicare Part B versus Part D, for example. There's obviously a lot of interest in, is there a benefit to combination therapy? To be clear, there were trends towards that from this trial, but we don't know that for sure. We'll get more data, but probably not a definitive answer for the CardioTransform trial, which will be coming out in the not too distant future. But right now, again, my role is not to say you should use this one, or this one, because I think we honestly have three good options. This is where I feel that data such as is being published here is helpful, because when there's not one absolute right answer, it is good to be able to break it down and say, well, let's look at these components of the primary endpoints and secondary endpoints. Let's look at what happens with long-term follow-up. And what we can say from this manuscript is vutrisiran works really well. It worked really well during the double blind. And when you look at all-cause mortality, the curves continued to separate even further as you got into open label extension. So a really good option, but I can't answer for you which of the three is the right answer, because all three of them are.
Well, I was hoping you did have an answer, but that's okay. I was going to pick your brain, but that guidance is truly helpful, and why it's so exciting to be in medicine. I'm sure your residents don't want one extra piece of new knowledge. They have enough, but once you've been out a few decades like you or I, this is a very exciting time to expand our armamentarium. Thank you so much. And if anyone who's part of the CardioTransform trial is listening, send your stuff to us. We want more data. We want to know what's going on. So bring it to JACC. Dr. Witteles, thank you so much.
Thank you very much.